First, welcome to the 17th Annual Global Conference. This is going to be an extraordinary couple days. At our global conference this year, we have 160 panels, participants from more than 50 countries, about 3,500 of the most important and influential people in the world. It's going to be an extraordinary event. I hope you have a great time and see any of us in the Milken Institute staff who can be helpful. By the way, I'm Paul Irving, president of the Milken Institute. Before we start our panel today, I just want to make a point about how this panel in so many ways reflects our work this year. The Milken Institute has been focused on health as a core part of its mission really from the outset, and this year has been the year of particular advancement, accomplishment in that regard. One of the things that we've done, and one of our panelists is Lynn Goldman from the George Washington University School of Public Health, is engage in our collaboration. Many of you have seen it in naming the Milken Institute School of Public Health at the George Washington University in Washington, D.C., the most important city in the world for public health. And we are very focused on two particular parts, I would say, of the health continuum. If you think about health in three pieces, there's prevention and wellness on one side, there's treatment and cure, treatment and care in the center, and research and cure on the end. Many of you know our work at Faster Cures on research and cure. That work continues and is a daily priority for us. We are equally focused on prevention, something that can have a massive effect on lives, not just in America, but across the world. So that leads us to today's panel, and I'm very, very pleased to introduce our chairman, Mike Milken, who, as you know, has been focused on health and health philanthropy for his entire career. Mike, thanks very much.
Thank you. Thank you very much, Paul. And we want to welcome you this morning for an exciting opportunity to focus on prevention and wellness. And just to set the stage at an economic conference, it's important to remember that more than 50% of all economic growth in the last 200 years has come from both public health and medical research. Today we are honored to have 5 individuals who at some point and earlier or a little later in their careers all received medical degrees among many other degrees. And if I take you back 20 years, where we had a scientific retreat of maybe 200 to 300 of the world's leading scientists, we were attempting to suggest there was some relationship between what went in your body and your health. This is 1993, 1994 in America, and most of them did not accept that thesis. And so after a great deal of negotiation, they agreed to allow someone to speak who was an MD, PhD on nutrition, but only at lunch. Now, we have come a long way since then, and the world has changed. And I think it's symbolic maybe if we started with Peter Attia and his own journey. And Peter was an athlete. He got his MD from Stanford. He was excellent in math, but he began to question some of these issues. And I saw that picture of you, Peter, when you swam in Hawaii. And I was noticing that not only you, but your wife was a little heavy in that picture when we stepped back. Why don't we start there? And why did you follow this path? What caused you to change your career and your focus?
Well, Mike, like you said, I started out with a pretty traditional path. I was a surgical resident at Johns Hopkins, and I think over the years I found myself getting really frustrated, not surprisingly.
Just one second. Can we maybe call up that slide 29? So we all get comments, you know, from our wives or our significant others constantly. So why don't we just comment about this?
Well, yes. The only reason my wife lets this slide exist is because I point out that she was 6 months pregnant and I was not. But to your question, you know, being a surgeon and dealing with the complications of diabetes, I found it very frustrating. As many of you probably know, once you're amputating the leg or limb of a diabetic patient, the likelihood that they're going to be alive in 5 years is very slim. And so I found it frustrating. I felt like I was putting on Band-Aids all day. And the second, I think, force that kind of got me here is sort of what you've alluded to. This was actually not the nadir of my personal health. It was actually a couple years later. I had just become the maybe 10th person to make the two-way crossing from Los Angeles to Catalina Island and back. And on that day in September 2009,
well, not everyone remembers those songs from the 60s. Why don't you let them know how far it is from Los Angeles to Catalina?
Yeah, it's about 25 miles. And so at the end of that swim, my wife said to me something along the lines of, you know, Peter, you're a wonderful swimmer, but you've really got to work on being less, not thin. And even though the initial sort of provoke was towards vanity, it turned out something more sinister was going on. I was actually pre-diabetic. So I was 36 years old, exercising 3 or 4 hours a day, following the food pyramid, you know, as closely as I could, and yet I had this horrible problem. And that really catalyzed me to sort of begin a lot of self-experimentation, a lot of exploration of the literature. And what I came away with was, one, the conventional wisdom obviously didn't apply to me, but perhaps more importantly, I found so much contradictory evidence and inconclusive science in the body of nutrition that I really felt that my calling was to sort of leave what I was doing at the moment and sort of think about a way to make this better. How could we make sure that there was clear and unambiguous insights about diet, the relationship between diet and health, so that everyone could know, full stop, what they needed to eat to be most healthy?
And Peter, I think it'd be interesting, how did your colleagues react to your changes, let's say career changes, over the last few years?
You know, it's sort of a mixed bag. I would say, for example, when I left Johns Hopkins, when I left surgery, I think a number of the attending surgeons there felt that I was committing career suicide, that I was leaving the best hospital in the country and a wonderful career behind. And yet there were others that were incredibly supportive. And in fact, one of the most supportive people of all was a guy by the name of Peter Pronovost, who some of you may know. He's an intensivist at Hopkins. And when I told Peter I was leaving, he said, just like Joseph Campbell suggested, right? The hero is the guy with the courage to pursue his bliss. And so whether I'm a hero or a coward, I don't know, but I felt encouraged to pursue my bliss.
So Dean, I think it was 1983 when you first walked in to visit me at my office and letting me know about the relationship between heart disease and nutrition and diet. Take us a little bit on that journey that you've been on over the last 30 plus years.
Well, first of all, I appreciate that what was considered a crazy idea at the time, you helped make feasible. I don't think we'd be here today if it weren't for you. So let me just publicly acknowledge my debt and appreciation for your support then and now. I got interested in doing this work when I was a second-year medical student at Baylor College of Medicine in Houston in 1977. And I was on Michael DeBakey's surgical service learning how to do bypass surgery. And you know, we'd cut people open, we'd bypass their clogged arteries, he'd tell them they were cured, and more often than not, they'd go home and do all the things that had led to the problem in the first place. They'd smoke and eat junk food, not manage stress, not exercise. So I, much to my parents' chagrin, like Peter, I changed what I was doing. I took a year off and began what was a series of studies showing that you could actually reverse the progression of heart disease by simply changing what we eat, how we respond to stress, how much exercise we get, and perhaps most important, how much love and support and intimacy we have. And we use these very high-tech, expensive, state-of-the-art scientific measures to prove how powerful these very simple and low-tech and low-cost interventions can be. And in a series of randomized trials, we were able to show that you could actually reverse even severe heart disease, and the more people changed, the more they improved. And if you can bring up slide 6, you can get a sense of what that actually looks like. This is a frame from an X-ray movie called an arteriogram, quantitatively analyzed. And you can see the narrowing in one of the main arteries that feeds the heart at the upper left. A year later in the upper right is less clogged. Usually it goes in the other direction. And because the blood flow is a fourth power function of the diameter, these small changes in blockages cause disproportionate improvements in blood flow, a 300% improvement in blood flow, which we measured using cardiac PET scans. And these lower left is at the beginning, blue and black is no blood flow. The lower right a year later, orange and white is maximal blood flow. And that's what we found. And then we went on and we found that these same lifestyle changes that could reverse heart disease in the first and still the only randomized trial to show that early stage prostate cancer can be slowed, stopped, or reversed as well. This is, by the way, with the heart studies. We found that the arteries got more and more clogged in the randomized control group shown in the red line, but less clogged after 1 year and even more improvement after 5 years in the green line. And we found that if we can go to slide 9, we found that the tumor growth was inhibited by 70% in the experimental group and only 9% in the control group. And in the next slide, in direct proportion again to the degree of lifestyle change. The more people change, the more it inhibited their tumor growth. And then finally, in this next slide, you can see that using a new test called MR spectroscopy that looks at the tumor activity, we found it was diminishing over time. And then we turned our attention to gene expression in the next slide, and we found that over 500 genes were changed in just 3 months to try to understand the mechanisms. Red is turned on and green is turned off. And you can see this is just after 3 months. And each of those is an oncogene on the side that controls prostate, breast, and colon cancer. And so in the final slide I wanted to show you is that we were able to show that we can begin to reverse aging at a cellular level. This is a study that we just published a few months ago in the Lancet Oncology, finding with Dr. Elizabeth Blackburn, who got the Nobel Prize for discovering telomerase and telomeres, the ends of our chromosomes that control how long we live. As our telomeres get shorter, our lives get shorter. And we were able to show for the first time that we could actually increase telomere length, in this case by about 10%, simply by making these same lifestyle changes. And so, in summary, although we tend to think of advances in medicine as something really high-tech and expensive, these simple changes in lifestyle can not only help prevent, but actually reverse the progression of these most common chronic diseases.
Dean, before we move on, I think it's important that maybe in layman terms, tell us what telomeres are and why we should be focused on them and why this study by Elizabeth Blackburn, Nobel Prize winner, and who was one of the leads on one of our other panels at the Global Conference, why this study is so important.
Well, telomeres are the ends of our chromosomes that they're sometimes likened to the plastic tips on the ends of shoelaces that keep your shoelaces from unraveling. They help to keep our DNA from unraveling. And as you get older, telomeres tend to get shorter over time. As they replicate, they lose a few base pairs and they tend to get shorter. And as they get shorter, your risk of premature death from pretty much everything, from heart disease, dementia, most forms of cancer, diabetes, you name it, goes up. And she had done a pioneering study where she found that women who were under chronic emotional stress, because they were caregivers of parents with Alzheimer's or kids with autism, the more stress they felt and the longer they felt stress, the shorter their telomeres were. But what was interesting, it wasn't the external, it wasn't something you could quantify. In other words, you could have two women in very similar life situations, but one was coping better than the other. And so it wasn't the external experience. You can't always control your environment, but you can control how you react to it. And so the women who felt stressed, their telomeres were shorter to the point where Dr. Blackburn and others estimated that it shortened their lifespan by 9 to 17 years. And so we were at a conference together when she presented that, and I said, we had lunch, and I said, you know, if bad things make your telomeres shorter, maybe good things make them longer. And sure enough, we found that after 3 months, the telomerase increased by 30%, and after 5 years, the telomere length themselves actually increased by 10%. And so that's important because it's really reversing aging at a cellular level. And now that I just turned 60, I have more of a personal interest in this than I used to.
Thanks, Tim. I think this is a very important concept. For many years, it would have seemed just common sense that what you're putting in your body has a major effect on your body. And so we know that most of healthcare cost is lifestyle. Now science is showing us that there's a direct link and you might be able to extend your life. So we are so focused on this area since 70% of all healthcare spending in the United States 70% is related to your lifestyle. And now these findings and work shows not only the lifestyle that's generating issues that could shorten your life, etc., bring on disease, but the reverse is quite possibly true. You might be able to extend the length and the quality of your life.
Hey, Mike, can I just say one last slide in that same context? This is slide 14. We found we could actually cut healthcare costs by 50% in the first year. This is data from Highmark Blue Cross Blue Shield. The first two bars, it's comparing people who went through our program to a matched control group. And the second shows that it was 50% lower in the first year. So there's this running debate. Even Doug Elmendorf, the head of the Congressional Budget Office, said maybe prevention doesn't save money, maybe you're just deferring costs. But if you're offering lifestyle as treatment, what's sometimes called lifestyle medicine, the cost savings are dramatic. And in the subgroup of people in whom Highmark spent more than $25,000 on in the preceding year, their costs were 400% lower in the subsequent year. So these approaches are not only medically effective, they're cost effective.
Thank you, Dean. Now, it takes a great deal of courage to change the world. And I'm going to call on Troy in a minute here to talk about that. But there's always this give and take between a for-profit and a nonprofit organization. And when you're involved with one of the largest companies in the world, and you make a decision that you know is going to discourage customers, some percentage of customers from coming to see you, that's a very difficult decision to make. Troy, likewise, you got your MD. What got you involved in these areas of prevention, wellness?
Well, I was always interested in public health and had a long career at the Harvard Medical School, but always worked at the School of Public Health there, and always saw that the more important set of interventions were going to be made from prevention and from promoting wellness as opposed to treatment. And fortunately, we have the opportunity at CVS to pursue that. I think people ask us, how can you leave $2.5 billion on the table in terms of revenues? And the answer is really one of integrity. It's kind of a no-brainer if you're trying to be a healthcare company and yet you're selling one product that's unalterably unhealthy. It just doesn't make sense. And I think as we've made our move towards becoming more and more of a healthcare company, as we reach out to work directly with physician groups and hospitals, and as we get more involved in a variety of treatments like home infusion and things like that, and as our pharmacists reach out more and more to try to counsel patients, and as we open more and more retail clinics, ours are called Minute Clinic, the company is really a pharmacy innovation company, and our goal really is to help people on their path to better health. And when you think about that, and you think about the sales of cigarettes, integrity alone says that you need to change what you're doing.
Troy, let's take a look at this announcement. We have a short clip here.
Turning now to what was behind the major announcement today by a national pharmacy chain that it will stop selling tobacco, even though it will mean losing billions in sales. The announcement caught the attention of a lot of people today, including the President and the First Lady. We get a report now from NBC's Tom Costello.
The news out of CVS today could represent a watershed moment. The biggest pharmacy chain in the country getting out of the business of selling tobacco in all 7,600 stores by October 1st. While most cigarettes are bought in convenience stores, not pharmacies, the pressure may be on the others to follow the leader. Tom Costello, NBC News, Bethesda, Maryland.
So, Troy, we have always felt that doing good is good business. And I think one of the things that there's been a strong feeling is, what do you stand for? What does your company stand for on that issue? What has been the reaction from customers, shareholders, and like since that announcement?
Well, the shareholders have been pleased. The stock is up, and there's a lot of people who are coming into our stores now to say that, we think you're walking the walk as well as talking the talk, and this seems like a place that's committed to healthcare, so this is where we want to get our prescriptions. So we hope that there'll be some improvement there. But I'd say it's more represented by a episode that occurred in one of our stores recently. One of our senior regional managers was there, and they're often in the store sort of observing behavior. And there was a customer who was berating the person working behind the cash register because we were no longer going to sell cigarettes and how inconvenient it was going to be for him, and isn't that terrible? And spontaneously, this person, one of our 240,000 employees, said, I think you're all wrong. This makes me so proud to work here. I feel like this is such a great place to work. So the intangibles associated with sort of following a high integrity move, I think are things that's very difficult to put value on, but extraordinarily important nonetheless.
And how is your relationship with some of the people you went to medical school or worked at, and Women's and Brigham and in Boston, etc.? How have they? Did you get any emails from them? From this spirit?
Well, obviously, yes. I mean, we still continue to work with a large number of them. And people in the healthcare organizations have been very encouraging about this. We have a very strong part of our company that reaches out directly to hospitals and physician groups and integrated systems. And we're in competition with others in the pharmacy space for that business. And they see us now as somebody who's endorsing values that they can support. So I think that's all good. I would say, from a public health point of view, one part of its integrity, one part of its leadership, and to extend sort of our leadership, we're actually taking a hard look, and we've got a number of investigators working with us on this to understand how much we could decrease overall rates of smoking if cigarettes were removed from all retailers who also had pharmacies. Turns out about 20% of cigarettes are sold in places that also have pharmacies. And so if we could eliminate those, and remember that our locations are amongst the most convenient places to get things like cigarettes, and also that over 40% of people who are smoking are dynamically trying to quit at this point, we believe that there could be a substantial decrease, maybe from 18.5% down to 15% overall prevalence rates of smoking. That's saving 60, 70, 80,000 lives and avoiding $100 or $150 billion in costs. So, we feel like this is the kind of thing where if you provide leadership, you can have a real impact on public health, something that businesses should be thinking about.
It's interesting when we think about that concept of selling cigarettes in a place that you have a pharmacy. It's not alone. Here's a picture of LA here, of a company where we have a slide 54, where we have one of our key weight loss centers, but it's located right next to the homemade ice cream and pie kitchen. So we do see these things as we travel around throughout the world. I would comment, if we could pull up slide 80 for a moment, that when we really began this focus on nutrition, prevention, wellness, the relationship, about 21 years ago at the Milken Institute and at many of our medical foundations, we noticed that less than 10% of the healthcare dollar was going really for research and cure and prevention and wellness. So if we're really going to stop a problem, I think we all recognize the easiest thing is to prevent it from occurring. But today, the work done by the Robert Wood Johnson Foundation has shown that less than 4 cents goes to public health and prevention of that dollar. So you could think about it if you were manufacturing cars, and instead of correcting the problem in the manufacturing process, you're just going to have the money being spent in the repair shop. If we look at the next slide, 81, you can see here that it's estimated just a $10 per capita investment in public health programs would save $16 billion. Now, with interest rates as low as it is, this would be one of the better investments we could all make. And if we took a look at, say, the next slide just for a moment, you can just see what a 1% reduction in the smoking rate that Troy has referred to. And if we look at 83, as we wind up this section, you'll see here that programs that are offered by 50% of the employers can have a dramatic effect. Steve Bird, CEO of Safeway for 20 years, revolutionized the care, increasing the quality of life and length of life for their employees. Now at Bird Health, focused on that. But $1 invested in a well-designed program, it is estimated that $3.30 is saved in healthcare, and $2.70 is saved in labor markets and productivity. And our study, which was put out in 2007 on an unhealthy America, really highlighted the fact that the out-of-pocket costs for health care were actually smaller than the other effects of absenteeism, presenteeism, and other things that occur in the workplace, and just the change in weight. Just the change in weight in America between 1991 and 2007 was costing the United States $1 trillion a year. So Lynn Goldman, Dean of the Milken Institute School of Public Health, has as many degrees as anyone I've ever met. And so, you know, the great medical school at UCSF, Berkeley, a couple degrees, Hopkins, a number of, has led you here, Lynn. And I thought maybe following your own career a little bit today and then giving us some insight, if you would, and maybe the design of a workplace, design of schools, and how does that affect individual health? Can we, through architecture, design, and movement of people, can we change health from that standpoint?
Thank you. Yes, I think that when I think back over my career, I also started in a medical setting, working in a free clinic, and I saw those effects of only 4 cents out of the dollar being spent on prevention, and that we would take care of people who were in terrible need. They would go back into the community, and it wasn't long before they were returning to us with exactly the same problems. And I felt that I wanted to move very much upstream of that into environmental health, into prevention, and find ways to change the conditions that were causing these serious problems. I think air pollution is a good example of that. Here in Los Angeles, when I started my career, you could hardly see across town. You looked toward the hills, you couldn't see the hills most days. And we don't have a choice about the air we breathe. We can't carry around little bottles of air to breathe. We need to clean the air and make sure that the air is healthy for all of us. And I think the same is true when it comes to the food that we eat, physical activity, smoking, that the environment has an enormous impact on our behaviors. We think that these things are involved with personal choice, but yet when we know that when cigarettes are available in machines and in the corner pharmacies and everywhere, that people will be smoking more. And the converse is true, that reduction in availability of cigarettes reduces smoking. We know that the availability of healthy food affects food choices, and that in fact when the foods that are made available, the portions are too large, they have too many calories or too much sodium, that people will eat that. We've all been taught to clean our plates. And the environment around food has a major impact on our choices about food. Me personally, if you put a plate of brownies in front of me, I will eat one. And I think that many of us would choose that unless we had a plate of fruit or other healthier choices. And the same is true for physical activity. So what are we doing on the George Washington University campus, like many work environments? We've been working to reduce smoking. We've actually established a smoke-free campus environment. We've made available to the employees the American Cancer Society program to help them with cessation of smoking. We are also making services available to our students through student health. We've been working on making the campus more walkable. We're fortunate to be in a city that has put in place bike lanes. We have bike racks all over campus. Some of my students are designing walking trails that people can use as an iPhone application to encourage walking on campus. In my own building, the School of Public Health building, the central focus is a staircase. Why? To encourage the use of those stairs at every time possible. Why wait in line in the gym for a stairmaster when stairs are available in the buildings where we work? So I do think that this environmental approach works. It's very cost effective, and it's something that we all need to adapt. It's not going to come from the top down. We all need to be engaged with doing it.
Thank you, Lynn. I think we pull up slide 23 for a moment. You can just see it is amazing how simple the opportunity to change the course for an individual is, and the idea that Dean has often pointed out is physical activity is one of the closest things we have to a wonder drug. And as we think about lifestyle and leadership of organizations, nonprofit, for-profit, government, etc., just the potential in this area. So our last initial comments are going to come from Tom Frieden, who runs the Centers for Disease Control in the land, and in many ways is in charge of monitoring the health, not only for everyone in the United States, but everyone in the world. As the world has become smaller and travel has increased dramatically, the importance of what the work the CDC does and the monitoring on the, throughout the world has become more important. And we had the honor at the Milken Institute to be able to host with the Centers for Disease Control under Tom's leadership a group of about 175 people that earlier this year visited the Centers for Disease Control. And it was really interesting to see. When we grow up, we hear about these situation rooms at the Pentagon, etc. But in reality, there's far more we're going to be dealing with in the world today in a smaller environment with the situation rooms that exist at the Centers for Disease Control. Tom, tell us a little bit about what is the Centers for Disease Control and why you were so focused on the Chinese New Year this year when we were visiting you.
CDC works 24/7 to protect Americans from threats, whether those threats are infectious diseases like flu, or chronic diseases like obesity and cancer, diabetes, heart disease, and stroke. And we do that whether they're coming from this country or anywhere in the world, whether they're naturally occurring or man-made. Chinese New Year is a time of amazing amounts of movement of people all around China. And that this past year's Chinese New Year season coincided with the re-emergence of H7N9 avian influenza. And of all of the diseases that scare us in public health, influenza is pretty near the top, or at the top, because of what the 1918-1919 pandemic did, more than 50 million deaths around the world. Flu is that kind of perfect storm in that it spreads easily from person to person. We have an okay vaccine, but not a great vaccine. New strains of flu are emerging all of the time, and those new strains, if they evade our vaccines and immunity, and if they spread readily, and if they cause severe illness, can cause terrible devastation. And H7N9, the new avian flu in China, in fact, combined almost all of those characteristics. A new strain, we don't have immunity to it, we don't have a vaccine to it, it causes severe illness. The only thing it didn't do was spread readily from person to person. So we've been tracking that very closely. We've had a decade of close collaboration with the Chinese government. They were completely transparent about it. They posted the sequences, the genomic sequences, within really hours of identifying it, and that allowed us to begin work on diagnostics and a vaccine.
Now, Tom, I think it'd be very interesting to compare and contrast when SARS first occurred and the interaction with China to that interaction today.
When SARS hit, China didn't handle it well. They recognized that. It cost the global economy more than $30 billion in just a few months. And if we could see slide 18, SARS is really one example of a new or emerging risk. We also have drug-resistant organisms. We also have, unfortunately, the intentional creation of organisms, which can be deadly. But we have tremendous commitment to address this around the world. We have new tools, and we have success stories from around the world. So what we're focused now on is to make sure that we're doing a better job finding problems wherever they emerge so we don't have blind spots, stopping them where they emerge, and preventing them wherever possible.
And Tom, we've read recently about some issues in West Africa and other parts in the Middle East today. Tell us how you're dealing with those. What happens at the CDC when these things occur? What do you mobilize? And how do we deal with these issues?
We have a 24/7 watch command, but we also have staff, 700 staff all over the US, nearly 2,000 staff all over the world, and most importantly, we have partnerships with other countries. In fact, we have trained more than 3,000 disease detectives in 2-year programs, the vast majority of whom, about 80% of whom, continue to work in leadership levels all over the world. And they find and stop and prevent outbreaks all the time that don't have to come to us. But when there's a situation like Ebola in West Africa, had not occurred there before, we work with other international organizations, other countries. We have a team on the ground there now. I was chatting with them a couple of days ago, and they were telling me that in one of the places we've done studies of Ebola and Marburg, a similar virus, is it's a cave. A lot of bats. Bats cause a lot of disease. And there's a large python in that cave and a deadly virus. And I was saying, you know, it must be pretty scary to go into that cave. And they said, well, actually, the python doesn't scare us. It's about a 15-foot python. And the Marburg virus, this Ebola-like virus, doesn't scare us. It's the cobras that scare us. There are cobras in the cave. So they wear not only these white suits that you see, but leather chaps under the white suits so that if they get a cobra strike, they don't die from it.
Tom, just, I think, you know, we've seen movies, we've seen things. What happens at the CDC? Does a fire alarm go off? I mean, give us a feeling here is how do you mobilize? And I don't really believe most people fully understand what the Centers for Disease Control does. I think one of the things that was very emotional for me, Tom, when I was at the Center for Disease Control was seeing that interview with an individual who had polio and was living in an iron lung. And we sometimes don't forget, and if you have an honor to visit the CDC, to see pictures of these entire indoor, what we would think of as a football field with people in iron lungs, keeping them alive because they had polio. My father had polio. And seeing this individual who I think had lived 5 to 10 years in an iron lung, speaking and seeing the iron lung that he was living in, and you might not remember, but the United States was preparing plans to build iron lung hotels throughout the entire country, and it was estimated the potential cost was going to run $100 billion a year by the year 2000 in America. Maybe take us quickly through the polio story, and then tell us when the alarm goes off that there's an event such as in Saudi Arabia, what actually happens on the ground? Who do you mobilize? What's happening? And how are you prepared for these incidents?
Well, first, starting with polio and vaccines more generally, polio used to disable more than 350,000 children a year, 1,000 a day. The world decided to try to eradicate polio completely. We're very close. Only 3 countries in the world have never gotten over the finish line, but because of that, they continue to export it to others. We're now flooding the zone in Nigeria to try to make sure that we get over the finish line there. Mr. Dangote has been very supportive in that. Bill Gates has been terrific. CDC has been in this fight from the beginning, and we provide people on the front lines. In the US, we had our last case in 1979, but globally, when we do get over the finish line, and I'm confident we will, it will be the ultimate in both sustainability and in equity, because it will be forever and for everyone. But polio is just one example of a vaccine. Just last week, we published a 20-year anniversary of the Vaccines for Children program. It's a wonderful program. It provides about half of all the childhood vaccines in the country. And you can't protect your kids effectively if all kids aren't being protected. We're in it together as a society. In these 20 years, and the kids born in
Tom, I think it's important just take one moment and explain why to the audience.
Something like measles is highly contagious. So if you don't get a high level of vaccine, even if your kid is immunized, they might get the disease. So we have what's called a herd immunity. We are all connected by air, water, and food. But what the data shows from the Vaccine for Children program is in this 20-year period, there were more than 300 million illnesses, more than 20 million hospitalizations, and more than 700,000 deaths prevented. And the return on investment was $295 billion in healthcare costs and nearly $1.4 trillion in general societal costs. So if you show slide 22, we know that the costs of illness are enormous and the return on investment for prevention is substantial. To answer your question, though, when the phone rings, they contact me, they contact my staff, and we identify what is the problem. how can we assess where it is, how severe it is, and what resources can we marshal locally to deal with it? That may be state and local health departments in the US, that may be global partners, that may be countries abroad. In fact, one of the things we want to do is to strengthen the ability of countries all over the world to address emergencies like this, so they all have emergency operation centers.
Thank you. Now let's step back. I think we're all aware that we've had some progress in some areas. And I think, Peter, if we go to you, well, let's compare what we did, say, in HIV and AIDS, where we've made significant progress over the past 20 years, with obesity. And as we step back to the Milken Institute, we felt in many ways that the area that we have not succeeded, in spite of enormous effort over the last 20 years. Could you compare and contrast those?
You know, perhaps it's a vestige of being an engineer, but we always love to do pattern recognition and identify simpler cases. And so when you look at that slide 25, the point of this isn't subtle, right? The slide is showing the mortality from AIDS in the United States from the early 1980s until today. And what you see is that the death rate from AIDS rose significantly during the 80s into the mid-90s, and then immediately began to plummet, as it continues to today. And while we haven't eradicated HIV and AIDS, it's certainly become more of a chronic condition rather than the death sentence it certainly once was. And so, you know, people in this room obviously have contributed to that, and it's remarkable. But the question is why? And so I think there were really two critical things that took place. The first was in the mid-1980s, was the correct elucidation of the trigger of AIDS, in this case, the HIV virus. So the HIV virus is what weakened the immune system. That's what led to this acquired immune deficiency syndrome. But remember, that alone wasn't enough. In this case, that slowed slightly the incidence, the number of new cases, as we began to at least understand how the virus was transmitted. But it yet wasn't an effective treatment. The effective treatment came in the mid-90s with the introduction of highly active antiretroviral therapy, or HAART therapy. And it was that introduction, not only of HAART therapy, but really, to play off what Lynn said, it was the availability of it that enabled this success story to take place. Now, if you look at slide 26, let's contrast that with where we are today with type 2 diabetes. Now, in the latter part of the 17th century, latter part of the 18th century, beginning of the 1900s, you took the largest series that looked at the number of people with diabetes in this country, one out of Massachusetts General Hospital, one out of Johns Hopkins. They pegged the prevalence of diabetes somewhere between 3 and 530 cases per 100,000 Americans. Now, by 1970, that number was up to 2,000 per 100,000 Americans. And today, increasing at a rate of nearly 4%, that number is over 8,000 per 100,000. And I believe Tom already shared with us some data on the cost of that, right? I mean, obesity and diabetes exacerbate these other 4 diseases that we've already talked about: heart disease, stroke, cancer, Alzheimer's disease. And so the total economic cost directly is about $1 billion a day in healthcare spending. When you factor in these indirect costs as well, we're talking about nearly $3 billion a day and 4,000 lives lost. And so the question I always ask myself when I go back to this is I contrast it with the previous slide, and I say, do we have this situation under control? Do we at least understand what the environmental trigger is of diabetes? Now, the conventional wisdom says we do. The answer is people need to eat less and exercise more. But if that's true, why have we been unsuccessful in making progress there? And so if you sort of think about it through the lens of a business, we have sort of a business strategy, and we have a business implementation. And similarly, there may be 2 problems here. Is the problem that our strategy is incorrect, that we have in fact identified the environmental trigger of diabetes and obesity, that it's simply people not being able to control how much they eat or how little they exercise? Or is it that we may have the wrong advice for people? Maybe we're missing something. And so I think of an analogy to put this in perspective. I was speaking with a friend a couple of weeks ago, very smart guy, and he's a pilot. And I was having this discussion with him, and he said, "Peter, you're ridiculous. How can you possibly say that we don't understand what causes obesity and diabetes? It's obvious that people just eat too much and don't exercise enough." And I said, maybe, but we've been saying to not do those things for 40 years, and we've put market forces policies in place to try to curb that. It hasn't had much effect. And I said, imagine planes were crashing every day and 4,000 people were falling out of the sky dying. Would we say we have a handle on aerodynamics and that it's all under control? I don't think so. I think we'd have a panel just like this where we'd say, well, maybe we don't understand aerodynamics as well as we think they do. And so I think that's what we have today, Mike. I think we have 4,000 people falling out of the sky every day, dying from these diseases that I think we would all agree are entirely preventable. And what I'd like to ask is, do we really have the treatment correct?
Mike, if I can disagree just a bit, because I don't actually think that we've put in place measures such as we might put in place to stop airplanes from crashing. So we regulate, the airline industry pretty strictly. And when a plane crashes, and once we understand why that happened, there's a pretty good process in place to make sure that that can't happen again. New rules are written, the planes are inspected, they're all, retooled, whatever. This is a very different kind of problem. This is not a problem that is amenable to that kind of engineering retooling, re-engineering the food supply. The data would show, actually, that this epidemic of obesity has arisen over a fairly long period of time, decades of gradual change in not only physical activity, diet, the habits of young people. Young people are more connected to screens today, certainly than they were when we were kids. Less physical activity in the schools. All of these things have evolved over decades. We actually haven't taken an approach to say, well, we're going to require PE in every school. We don't. We don't have daily physical activity. We don't have ways to limit the screen time that children have, or for that matter, to regulate the caloric content of food. Remember when Mayor Bloomberg tried to change the size of the drinks that are the sugary drinks sold in New York. And I'm afraid it's a problem that isn't amenable to that kind of approach. I think that this is a problem that is going to need to involve employers. It's going to need to involve the schools. We have to focus a lot of attention on our students. It needs to involve the medical profession. I don't think that our physicians, nurses, other healthcare providers really are doing a concerted effort in this area. And not because we don't know about it, but as Dr. Frieden has reminded us many times, we're not even controlling hypertension clinically when we know that that needs to be done. And so this effort to marshal prevention, of slide 100, I think needs to bring together the scientists, people who understand these issues from the molecular level all the way through the population, academics, if you may, but also philanthropy, private industry, and the government, all of us in partnership. It's a complicated issue, but it is tractable. We can do this, and we must do this. It simply isn't right to continue to allow people to become ill, to treat their illnesses. It's not just the expenditures, but it's also the pain, the suffering, the premature death that we could be preventing if we could take a more preventive approach.
Now let me come back to you in 1 second, Dean. Troy, I think one of the issues, as a doctor, as a lawyer, how do you balance these public health initiatives with constitutional limitations? And how do you find the balance between nudging and individual liberties? As Lynn has pointed out here, we have a chain that could lead to a new system. How far would CVS and Caremark go in this area? Where do you see the role of your company representing the for-profit company on this session?
Well, I can't say much about constitutional law. My professor of constitutional law was Robert Bork, and we spent relatively little time on most of constitutional law. But I would say that there obviously is sort of inherently a set of individual human rights that are going to be protected by our Constitution, narrowly focused on issues surrounding sort of liberty and somewhat around equality. Then there's a set of sort of human rights issues about sort of, are we making the right steps with the way in which we elaborate our medical care system to include both treatment as well as prevention. I think that from our point of view, as a company, we're obviously very respectful of the Constitution and of our customers' choices, because that's the important thing. But we feel like we can't orient them towards the right choices. So we talked a little bit about before the session started about nudging. We feel like it's reasonable to sort of take advantage of the fact that people aren't always completely rational about their choices in order to offer them choices in an appropriate way. Just like many companies today will automatically sign people up for retirement savings, so too, we're trying to sort of display choices in ways that will orient people towards making the right choice from a public health point of view. So I think that very readily, our commitment to individual liberties and a commitment to public health can nicely be coherent.
On that issue, if we can just see slide 17, what does government fundamentally do in public health? And I think there are 3 areas to be responsive to what people want to live freely. We increase freedom in critical ways. One of them is by promoting free and open information so people, policymakers, can make more informed decisions, whether that's about tobacco or nutrition or any other area of health. The second way we increase freedom is by protecting individuals from harm caused by others. And that might be by drunk driving, that might be by secondhand smoke, that might be by things that are in your food that you didn't know were there but might kill you. And we increase freedom by taking societal action to protect and promote individual health in some of the ways that Lynn was mentioning earlier. It's one thing to tell someone to eat healthy and get more physical activity. It's another to make sure that they have a realistic way to do that. So whether that's vaccination or fortification of food or zoning that makes it easier for people to get physical activity or initiatives that do that, our actions as a government increase freedom. And I think the legal system sometimes has challenges with that as currently interpreted, but I don't think there's anything against the fundamental concept that what we're trying to do is increase freedom and control.
I'd just add to that, in these pictures here sort of remind me that CDC is going to launch a new campaign with regard to sort of public relations and getting people oriented towards trying to stop smoking. These are the kinds of things that we're going to bring directly into our stores, and at the same time as we begin to take tobacco out, we'll have much more featured cessation products. So it's still a matter of individual choice about what people want to do. But for that 40% of people who are trying to decide if they're going to quit smoking or not, being kind of inundated with cessation rather than being inundated with cigarettes, they'll probably make the right choice. And that's perfectly an American thing to do.
Dean, let me go over to Dean just for one. Dean, you have been a leader, maybe the leader in America, in pushing for reimbursement for prevention and wellness. Mm-hmm. And there are many people that feel that we need to have it reimbursed in some sense, count, in order to really get a movement going. I'd love you to comment on this discussion, but also talk about that experience.
Okay, well, let me start with that. You're right. I used to think if we just did good science, that would change medical practice, but in retrospect, that was a little naive. If it's not reimbursable, I found it's not sustainable. And so we spent 16 years in a dialogue with the Center for Medicare and Medicaid and CMS, and after 16 years, they agreed to cover our program as a Dr. Dean Ornish program for reversing heart disease. They created a new benefit category. We got an act of Congress passed. Mike, you know what it's like trying to get the government to do something. We're very grateful to Medicare for doing that. I was talking to someone else in the government and said, it took us 16 years to do this. And they said, only 16 years? That's how things go sometimes. And now that it is reimbursable, most of the other insurance companies, WellPoint recently agreed to cover it for its 35 million members in 14 states. Most of the other payers are doing the same. And so finally, we can create a new paradigm of real health care rather than sick care, because if it's reimbursable, then it's sustainable. And all the forces, I think, are converging to finally make this the right idea at the right time. First of all, the limitations of high-tech medicine are becoming clear. Many people are surprised to know that the randomized trials, for example, of angioplasties and stents show that they don't work. Unless you're in the middle of having a heart attack or you're really unstable, which most people aren't, they don't prolong life, they don't prevent heart attacks, they don't even reduce angina. And the same is true for bypass surgery. And we spent almost $100 billion last year on these 2 interventions that are dangerous, invasive, expensive, and largely ineffective. Treatments for prostate cancer don't work that well for people with early stage disease. Most men are going to die with it, not from it. And lowering your blood sugar with drugs doesn't work to prevent the complications of diabetes nearly as well as if you can get someone's blood sugar down adequately with diet and lifestyle, you can prevent all the horrible amputations that Peter was talking about, the blindness, the kidney failure, the heart attacks, the strokes, the impotence, and so on. If you get someone's hemoglobin A1C down below 7 with diet and lifestyle, as we've shown over and over, you can prevent every one of these. And United Healthcare estimated that half of Americans are going to be diabetic or pre-diabetic in the next 6 years at a cost of $3.3 trillion, clearly not sustainable. But and also as we move into the era of Obamacare, whatever one thinks about it, it really turns a lot of the incentives on their ear. So before, in a fee-for-service environment, the more procedures like stents and angioplasties you do, the more money you, the doctor, or the hospital or clinic makes. But in this new era of medical home and integrated delivery networks and so on, they'll say, here's X amount of dollars to take care of someone. You, the doctor, hospital, or clinic, gets to keep what's left over. So it becomes more value-based than volume-based, and the fewer procedures you do. And so that's why I think it's a perfect storm. And finally, the other mega trend is that we're showing that these simple lifestyle changes can reduce healthcare costs so dramatically and so quickly. But I want to move into the area that we've been talking about for the last few minutes, which is, what really causes this obesity epidemic. And I want to separate, what we need to do about it from what's causing it. And I think they sometimes get conflated, and I think it's important to look at them separately. What's causing it, I think there's a tendency in medicine to be very reductionistic. Oh, it's all too much fat. Now it's too much sugar. And it's actually too much fat and too much sugar and too little exercise and too little social support and too much emotional stress. All these things really make a difference. And one of the reasons that I like science is it really is a way for people to sort out what's true from what isn't and what works from what doesn't. And I really applaud what Peter and Gary Taubes are doing with the Nutrition Initiative to try to bring more science to this. I think that's really critically important. But I also want to emphasize that there are a lot of false choices in here, and that it's not enough to focus on the behavior. We need to focus on a deeper level. I asked people in our studies, we got to know them really well, why do you smoke and overeat and drink too much and work too hard? These behaviors seem so maladaptive. And they'd say, you don't get it, Dean. These behaviors are very adaptive because they help us deal with our loneliness, our depression, our isolation, our alienation, our pain, with the breakdown of the social networks that used to give people a sense of connection and community. I'm struck by the work that Nicholas Christakis did at Harvard, where he found that if your friends are obese, you're 45% more likely to be obese. If your friend's friends are obese, it's 25%. And if it's your friend's friend's friend that's obese, you're 10% more likely to be obese, even if you've never met them. That's how interconnected we are. And so information is important, but it's not enough. If it were, nobody would smoke. It's not like your doctor says, hey, did you know smoking's bad for you? And go, I didn't know that. Thank you. I'll quit today. You have to work at a deeper level. And the final thing I want to say in this area is that it's important to lose weight in ways that enhance our health rather than compromise it. And I was in a number of debates with Dr. Atkins before he died, and I was always a low-fat guy, and he was always the low-carb guy. And it's really so much more than that. And if I can ask you to bring up slide 2, there have been a number of studies that have done comparing a so-called Ornish diet with an Atkins diet or variances of that. And they'll say, well, the risk factors aren't that different, so eat whatever you like because that's all that really matters. But what's important is that we do studies that look at the actual underlying disease process. And this is from the New England Journal of Medicine, from Stephen Smith's work. He was actually quoting Edward Fu's study. And this was done in mice, but I think it's true in humans as well, that the top is what happens when you go on a whole foods plant-based diet that's low in refined carbs and high in good carbs. The middle is the more traditional American diet. It's partially clogged. The upper is no clog. And the bottom is more a high-protein, low-carb diet. And yet what's interesting in these studies is that there wasn't that much difference in the traditional risk factors like cholesterol and blood pressure. But if you look at what they term non-traditional risk factors, non-esterified fatty acids and things like that, that's where you find it. And so it's important that we not only look at the risk factors, but the underlying disease. And if you bring up slide number 3, it talks about these non-traditional risk factors, including the low numbers of circulating endothelial progenitor cells, which are like Pac-Man that do that, and also higher levels of non-esterified fatty acids that promote inflammation. And the final slide on slide 4 is, this just came out last month, that showed it's not just the fat or the sugar, it's the protein itself that makes a difference. That consuming a diet high in animal protein, people had these are in people, not rats, had a 75% increase in total mortality, a 400% increase in cancer risk, and a 500% increase in diabetes. And so when we look at the plant-based diet versus a meat-based diet, it's beneficial in ways that we're only beginning to understand.
Dean, I want to touch base. During the global conference in 2014 on this issue, we have 30 sessions on medical research, prevention, wellness, forms of treatment and care, new technologies that we think will revolutionize this area. But I think you've touched on the issue that today we have far more facts and initiatives led by Peter, et cetera, to get more science into this, so we can support this data. You know, it's interesting, there are other studies going on from the insurance industries today on how quickly a woman loses weight after delivering, after the baby is born. And the initial studies show that if she does not get back to her initial weight within 6 months, the whole family is heavier. Not just the woman, but the father, the children, etc. from those. Now, we did have a countervailing thought put forth by Danny Kahneman, a Nobel Prize winner, and a psychologist from that standpoint, one of the few people who was not an economist to win a Nobel Prize in economics. But his comment when asked by college students at leading universities, why do you smoke? His view was they have a great deal of faith in the medical research system in America. They have faith in Dr. Collins. They have faith in Dr. Frieden. And before they get lung cancer, they expect there'll be a pill to reduce it. So it wasn't totally a logical act. It was their sheer confidence in the system. When we did a poll, only 1% responded positively to that idea. So we don't know if that one is accurate or not. But Tom, these are important issues. And Dean has addressed just how difficult it is to begin to get government to change, whether it's reimbursive and incentive. And so somewhat private industry has had to take the lead here. You know, you've dealt with movement in government and challenges in government, and the fact, I don't think people understand fully how little the funding is for the CDC, that not only monitors the health of everyone in this country, but today now monitors the health and intervenes with every country in the world. Why don't you give us a feel for the funding and then maybe pick up this last issue?
Well, our budget really doesn't allow us to do what we'd love to do to keep Americans safer and healthier and drive down healthcare costs. We had one little experiment.
Could you tell us what your budget is?
About $6 billion a year on the discretionary side. We also have vaccine purchase. But we had one interesting experiment. During the stimulus package, there was a program called Communities Putting Prevention to Work. And we funded health departments, community organizations, non-governmental academic centers all over the country to try to promote prevention. What we found actually was that more than 40 million people gained access to easy physical activity. More than 40 million people gained access to healthier foods. Nearly 30 million people were less exposed to secondhand smoke. And we've just completed a preliminary cost-benefit analysis from that showed that for every dollar spent in the healthcare field alone, we saved at least $5 over 10 years. The problem we have often is a wrong pocket problem. We have to spend it from our pocket, but we save it in someone else's pocket. And in society, we don't have a way of internalizing that to make sure that we actually invest in the things that work. We think a lot at CDC about the concept of scale, scalability. How can you go from a good idea to actually impacting millions of people? And I think that's one of our greatest challenges when it comes to wellness. If we can have slide 21, we've thought of this as the leading edge of scale. We can prevent 1 million heart attacks and strokes over 5 years by community prevention and clinical prevention. They both work together. They're synergistic. We need things in the community like tobacco control. Every time we run hard-hitting ads, millions of people quit smoking. In fact, it costs about $480 to save an American smoker's life through a public education campaign, and yet we don't have enough money to run it for more than about 2 or 3 months. Reducing sodium, eliminating trans fat, these work in the community. In the healthcare field, we need to improve blood pressure control, for example, and Troy's group and others can be tremendously helpful in that. Just as we need community and clinical work together, individuals need to take responsibility and government needs to take responsibility.
Could you just address this issue of blood pressure a little more? I think it's important.
Slide shows here that actually high blood pressure is the only thing in the world that kills more people than tobacco. And around the world, only about 1 in 7 people with high blood pressure has it under control. If I look at all of the things killing people and all of the money we're spending to deal with them, high blood pressure may well be the most neglected of all of the diseases. In the US, only about half of Americans with high blood pressure have it under control. And we need an all-of-the-above approach. If you get physical activity, if we can reduce the sodium in the food supply, if you get people moving, you're still going to have a lot of people who need to take medicines for high blood pressure. And if you improve clinical systems, you can drastically improve that. And we have systems around the country, big and small, rural and urban, that get to 80–90% control, not the 50% that we're settling for in our society. So we can deliver more value for our healthcare dollars if we focus on what the health return is going to be.
Thank you, Tom. I think one of the things we'd like to do is go to each of our panelists today and say what 1 or 2 things, very shortly, if we look back a year from now, that could have occurred that could have dramatically addressed some of these issues. Peter?
You know, I think the thing that I always ask myself is, how do you hedge your bet? So I'd be the first to admit I have sort of an alternative view of things. I'm not convinced we know the answer. We might. Maybe the odds are stacked in the favor that we do, and that it's simply a problem of our failure to implement them, combined with poor willpower and other factors that have all conspired to leave us where we are today, where 2 out of 3 Americans are overweight or obese, and nearly 1 in 10 have diabetes. But what if there's a tiny chance that the problem in some way stems from the fact that we don't actually know what we know? You know, Mike alluded to the fact that we have more information than ever before. And I think that's true. I call it a signal-to-noise problem. I'm sure many of you can appreciate that every day there's a new headline. Eat this, don't eat that. This causes cancer. Nope, this causes cancer. Actually, it was this that causes cancer. I think it's time we find out. And I think we actually have the ability to do that. And even if you think the probability is unbelievably slim that the advice we're giving today might actually be incorrect, when you look at the asymmetry of the cost, how can we not justify that hedge? Isn't it worth absolutely knowing for certain what the prescription is before we write it? You know, smoking is a great example, right? When you look at the studies of the 40s and 50s that unambiguously elucidated the trigger between tobacco and emphysema and lung cancer, it's because of that, I would argue, that everything that Tom, Lynn, Dean, everybody has talked about, that's why it's been successful. In fact, if you could just quickly pull up slide 27, you can sort of see the per capita consumption of cigarettes superimposed on the death rate from lung cancer. And the red triangles represent the clear and unambiguous scientific elucidation of that. And the blue and the green triangles illustrate the policy and market responses. And this is what the critical confluence is. You have to have unambiguous scientific elucidation of fact coupled with policy initiatives, market forces, and that's what results in the behavioral shift. This is about creating a non-toxic environment. I completely agree with what Troy said, which is we want to put people in the right default. Nobody's about saying you can't eat this or you should never be allowed to smoke or do X or Y or Z. The point is we don't want that to be the default. I'm just trying to figure out what the default should look like.
Troy?
Michael asked me if I brought some slides, and I got like 10,000 slides in my computer, but I didn't really want to refer to any. Had I referred to one, I would refer to a slide that Andrew Dreyfus, who's the president of Blue Cross Blue Shield of Massachusetts, put together. And what he does is he sort of compares where healthcare costs were in Massachusetts even after healthcare reform and how much they've increased over the course of the last 4 years. Something about $5 or $6 billion that the Commonwealth has had to absorb in increased costs for its employees, as well as costs across the state. And then how are those costs balanced? What he shows is that actually $4 billion came out of the state budget in the areas of public health and prevention. So what we've got is a healthcare system that continues to emphasize acute treatment and underplays the importance of prevention. So I think for individuals, you have to ask yourself sort of what is your, if you're in the healthcare system, what is your public health play upcoming? And Michael gave us the opportunity for two. I'd say I have two. One is, I've already alluded to, if we could get the rest of the retailers who have pharmacies, especially since the American Pharmacy Association says it's unethical to sell tobacco products in a place where there is a pharmacy. If we could get the rest of those retailers out, then I think we could see a substantial decrease overall in rates of smoking. So no longer would they have the excuse, if somebody doesn't buy the cigarettes here, they'll just go somewhere else to buy them. Actually, rates of smoking will decrease. And the second thing for us, as a company that's basically a $130 billion company in the middle of pharmacy, it's really about these sort of simple chronic diseases we've been talking about. High blood pressure, diabetes, hyperlipidemia, good, cost-effective generic therapies for those. Our challenge is just to make sure people are taking their medications, because as Tom pointed out, only about 50% of people have control. That's because all the statistics we have from looking at both 65 million people who are in our pharmacy benefit management company, as well as the 7 million people who are walking in our stores every day, they're not taking their medications. So as a business, it's up to us to try to figure out how to get them to take their medications. And as a business, that's good for our business. So those would be my two things.
Dean?
Yeah, I want to just say that while we always need more research, I'm a researcher first and foremost, I think we know a lot more than we think. We've found that the same lifestyle changes, a healthy, whole foods, plant-based diet that's low in refined carbs, moderate exercise, stress management, including yoga and meditation, and perhaps most important, more love and support and intimacy, can reverse heart disease, can begin to stop or reverse the progression of early-stage prostate cancer, change gene expression, reverse aging. And we also found that the average person lost, in our randomized trial, 24 pounds in the first year, and 5 years later, it kept 12 of those off. We have data now on over 4,000 people showing that there's an average weight loss of 16 pounds, and this is with 85 to 90% adherence in West Virginia, Nebraska, and Pennsylvania. So I think we know more than we thought, but it's implementing that, I think, is really where the key needs to be. We need to collect more data, but I think that, there are just so many misconceptions about what enables people to make sustainable changes. And it's not fear of dying, it's joy of living. And because these underlying biological mechanisms are so dynamic, when people begin to make these changes, to the degree they make them, most people find that they feel so much better so quickly, it reframes the whole reason for change from living longer to feeling better. Otherwise, it's like that old joke, am I going to live longer, or is it just going to seem longer? Or Woody Allen said, you can live to be 100 by not doing all the things that make you want to live to be 100. That's the kind of the ethos that I think we need to change, and that's why conferences like this are so important.
Thank you, Dean. Lynn?
Yeah, I would say I would focus on research, and I think we specifically need research that's directed toward prevention. Some of the things that I think are huge opportunities, one is to keep antibiotics working. We have a real problem with the evolution of our microbes that are pathogens toward being resistant to antibiotics, and lots of antibiotic-resistant infections in the hospitals, some of which are coming from the use of antibiotics clinically, some of which are coming from agricultural uses. This is a huge problem. I hate to see us go back to the 1930s when we can't treat infectious illness. The other thing that I would say is, with the issue of smoking, it's an area where there's a tremendous disparity. It was mentioned that there are these social networks where people continue to smoke, but those tend to be people who are less educated, who are poorer, and they are not necessarily a part of our social networks. What we're finding with our research, I think we need more of that research, is that we need to reach into those networks and use those networks to help people to quit. That we can't expect that the same messages that have resulted in the reductions of smoking that we've seen to date are going to work for the people who continue to smoke. Childhood obesity, how do we prevent that? How do we protect our children from a lifetime of chronic disease because they're starting out obese in the first place? We need to review the evidence in a very systematic fashion and understand what's working and what isn't working, and move as quickly as possible to move these better practices into communities. CDC's doing some of that, the schools of public health are doing some of that, but we need to bring that together. This is an emerging public health crisis with a generation of children, the first generation in a century who will be less healthy than we are if we don't do something about this.
Thank you, Lynn. Tom?
Implement what works first and foremost. If we had cure for millions of people with fatal cancer and we didn't implement it, we would be outraged. And yet that's exactly what's happening with prevention. We know what to do, we're not doing it. We're not empowered to do it by funding, by support, by focus. So first and foremost, tobacco control, as Troy indicates, societal changes, as Lynn indicates, and as Dean indicates, programs that work for individuals. But second, learn more. Analyze those things. So we're on a pathway to always be improving our programs. They're never perfect. We're always going to learn more. We need to understand more what's driving some of the trends, but that should never be an excuse for inaction.
So as we look at data, if we could pull up slide 47, we could see where the country was just a little more than 20 years ago. This work that was done by Bill Dietz, who now heads the Redstone Global Center for Prevention and Wellness at GW, it was really concentrated in only 4 states in the country. By 2002, just 11 years later, 2001, Colorado, but in 2002, all of the states had gone over 15%, and a couple years later, another decade later in America, it changed dramatically with a number of states over 30%, those 25 to 30, and just a few of them under 25%. And so what we're seeing here is what's really occurred, as Lynn was saying, it's over a few decades here. This isn't something that existed over a long period of time. The challenge to all of us that's been given by the panel can be seen just by looking, say, at slide 55. The California State Fair introducing new foods such as chocolate-covered bacon or deep-fried butter, etc. These are the foods that were the most successful new foods being introduced. And it's not just California. If we look at 56, for example, we can take, or 57, we can take a look at Minnesota just last year. These are the new foods being introduced in candy, bacon, cannellonis, etc., double bacon, corn dogs. These are the foods still being introduced in America. And slide 57, you know, you're concerned you're not consuming 6,400 calories a day, which would allow you to put on potentially 1 to 2 pounds a day extra weight. Well, they have a thing. You come to this fair, you can follow around, and if you follow this diagram, you'll be able to consume 6,400 calories on just one visit to the Minnesota State Fair. So there are challenges, and one of the areas that Peter put is the challenge of policy. If we take a look at slide 39, you can see why, besides for the enormous talent of Steve Knapp, president of George Washington University, and Lynn is the dean of the School of Public Health. Well, what isn't within a mile or 2 or a block of GW? Well, the FDA's there, the CDC has an office, Faster Cures are centers there, national economies, Congress, the White House, the World Bank, the World Health Organization, and so on. So all we're going to ask them to do is get a little exercise, walk 1 or 2 blocks to visit the School of Public Health. But in closing, I don't think we can stress just the challenges. Let's talk about the successes. And probably the greatest achievement that's been achieved and the benefits of all of our panelists today, their work, is to be seen in the extension of life. And if we look just, say, at slide 40, just to see what we have accomplished in the United States. Many of these deadly diseases have not only been controlled in the United States, but around the world. And as Tom referred to, measles, smallpox, yellow fever, polio, etc. The promise for a better life, a higher quality life, less medical expenses, and also enormous economic growth lies with our advances in prevention and wellness. And thank you for joining us today.
Thank you.